Our second part here of chapter 8 is going to look more at the movement part of the joints. So if we look at the different types of movement, they're classified as gliding, which would be in those plane joints, so a little bit of movement here. Angular, which of course angle between the bone changes. So some terms that we'll see as we go through these: angular motions, flexion and extension. And then we have some subtypes of these: hyperextension, plantar flexion, dorsiflexion. So again, they're all types of flexion or extension. Then we also have abduction and adduction that are moving from or away, so away or toward the midline. We have some circular motions, so we have rotations, pronation and supination, and then also circumduction. And then there'll be a few other special movements that we'll go over as well. All right, so starting first with the angular motion, so flexion and extension. So flexion is just movement of the body part anterior to the coronal plane. So that's a lot of things to say, that it's moving up toward the brain, or up toward that coronal plane. So if we're flexing it, we're going toward the brain. Extension is essentially the opposite. It's going to the posterior part of that plane. So the anterior part is up here at the brain. Posterior part is down here at the feet. Again, our coronal plane, moving through the body. So then extension, again, would be going away or toward the bottom. So more toward our feet. Flexion is moving more toward the head. Now, dorsiflexion and plantar flexion, subtypes here of our flexion. So again, still moving toward the brain. Plantar flexion is going to be standing on the toes, whereas dorsiflexion is where the foot is going to be lifted toward the shin. All right, so again, dorsiflexion, we're coming up. So this is all at the foot. So dorsiflexion is coming up. Plantar flexion is going to be pushing down and toward the toes. So if we're standing up on our toes, if we are flexing that, that's pushing us up on our toes. That's called plantar flexion. If we're bending the foot so that our toes are popping up, so we're walking more on our heels, then we have the dorsiflexion. So think standing on your toes, plantar flexion, you're planting your toes. Dorsiflexion, you are standing on your heel. Now, abduction and adduction. Abduction, now we're talking about the median plane. Okay, so flexion and extension are talking about that coronal plane. So moving either anterior or posterior. Abduction and adduction are looking at the median plane, so right in the middle of the body. So abduction is going to be away from the middle, and adduction is going to be going toward the plane. So we're adding it to the plane, so toward the plane. So again, abduction, if we use our arm for an example, so if we lift our arm up, our fingers are now further away. So here's our midline. So we're moving that away from the midline. If we bring it down, we're moving closer to the midline. So that is adduction. Again, if we now look at the hand, so our little dotted line here is showing that median. So abduction is going to be moving away. So spreading your hands out would be moving your fingers away from the midline. And then closing them would be bringing them toward that midline. So again, the median plane can vary whether we're talking about the middle of the body or the middle of our hand. So again, it's kind of relative, but the median referring to the middle. Now our circular movements here for rotation. So this is one we're kind of familiar with, but we are turning on that long axis. So we can have kind of combine these. So we can have a medial rotation. So this is where it's moving and it's moving toward the midline. We can also have a lateral rotation that's moving more away from the midline. So again, depending on which direction we're going, but again, rotating is just moving in a circle. Now, circumduction is a combination here of flexion, extension, abduction, and adduction. So if we kind of put all these things together, we get circumduction. And this is going to be kind of that rotational. So again, we're getting a rotation here. So if we're doing arm circles, you know, like getting ready to do some swimming laps or something. So swimmers do these a lot, but a lot of other warm-ups use just rotating arm circles. So that is circumduction, because again, we have some various movements that we already mentioned here. So get rid of that. So again, here we have our arm. So here we are moving it up. Okay, so would that be flexion or extension? Take a second. Okay, so if we're moving up toward the anterior, okay, that's going to be our flexion. Okay, then we get extension is we're going toward the posterior, so combining those two movements. But then also, get rid of those, also with our abduction and adduction, we are also at different points moving away from the midline. So again, is that abduction or adduction? Okay, hopefully you said it's abduction. So it's moving away, and then as it comes back in that rotation, now we're moving closer to the midline, so that would be our adduction. So again, circumduction is using a lot of those terms in a circular motion. All right, now we have pronation and supination. So pronation, these are again kind of unique little rotations just of the forearm. So pronation is when the palm faces posterior, which is the bottom, the post. So pronation is when your hand and palm are pointing so that your palm is down. Supination is where it is facing anterior. So your palm is facing up. So again, pronation, palm down, supination, palm up. A way to remember this is if you're holding a cup of soup. So soup, you would need to have your palm up to hold the soup. So supination would be that palm up. All right, so then a few different types of special movements. So we have elevation and depression, protraction and retraction, excursion, opposition and reposition, inversion and eversion, and then some of those combination movements like we've kind of already seen with circumduction. So looking at these, if we are protracting, we are gliding anteriorly. Retraction would be moving back to its normal position, or even maybe further posteriorly. So if we think about the chin, protracting your chin would be going anterior. So again, kind of it's moving up toward your brain. So you're pushing it out, kind of moves it up as well. If you're retracting it, whenever you bring your chin back in, again, your head kind of tilts and your chin is more pointing down to that posterior part. Whereas if you're protracting it, it kind of leans up a little bit, which is that anterior movement. Elevation and depression. So elevation, we're going superior, so we are going up. Again, superior is the top. Depression would be going inferior, which is pushing something down. So like shrugging your shoulders whenever you come up is elevation. Going back would be your depression, or either further pushing them down. Excursion here, so we have lateral and medial excursion. So lateral is moving the mandible is all we're talking about here with excursion. So if you're kind of like twisting your jaw a little bit. So if you move the mandible to the right or left of the midline, then we have that lateral excursion. Medial would just be returning it to the midline. So here we have lateral excursion going to the right where we're kind of pushing our jaw out, and then lateral excursion to the left. Now, opposition and reposition. Opposition is where the movement of the thumb and little finger are coming together. So we're bringing them, so if you're doing like Scout's Honor or something like that, and you're bringing your thumb and pinky together, that is opposition. Reposition is that return to anatomical position. Then we have inversion and eversion. So inversion would be turning the ankle to where the foot is going medial, and then eversion would be turning the ankle so that it's more lateral. Okay, so again, inversion. So again, if we look at our foot here, so we're moving it more toward the midline. So the other foot is here. So we're bringing our feet together so they're going toward that midline. So inverting our feet would be bringing our feet toward the midline. And then here, if this is our midline, pushing the feet out there at the ankle. Again, our other foot would be here. It would be pushing out. So we're going away from the midline. That would be our eversion. So if we're putting our feet together, pointing our toes together would be inversion. Pushing them out or apart would be eversion. All right, so then wrapping up this chapter, looking at different types of range of motion. Or actually not wrapping up the chapter, but wrapping up the section. So range of motion here. Sorry to get your hopes up. So we have active and passive movements. And as the name implies, active is going to be muscle contraction. So we need some energy for that contraction. So that's active. And then passive is going to be some outside force is causing that passive movement. So we're not extending any contraction. We're not expending energy, somebody else would be. So both of these, though, are influenced by a few things. So the shape of those articular surfaces, so if the bones kind of get deformed or something, that can alter that range of motion. The amount and shape of cartilage, so we hear a lot about like knee replacements and that, where the cartilage is completely destroyed. We have bone on bone and really limits that range of motion. The strength and location of ligaments and tendons, the tissue that's around them, like the muscles and adipose. So as individuals, like if they're at the obesity level, all that extra fat around the joints limits their range of motion. The amount of fluid in and around the joint, of course, pain in and around the joint, and then use or disuse of the joint. So if we're not using it, they get kind of stiff. And that range of motion is going to decrease. All right, so some abnormalities in that range of motion. So we can get dislocations, or also called luxations. This is where that bone, that articular surface, has moved out of proper alignment. So it's not lined up with the connecting bone in the right place. So it is out of location. It is dislocated. Subluxation is partial dislocation, so it's not quite lined up, but it's just off a little bit. And then we also can get some sprains, which are going to be damage to those ligaments from stretching, or they can become completely torn, and those are different types of sprains. Now we're going to focus a good bit on the knee, just because there are so many knee injuries. This is very common. So really understanding the knee joint, lab focuses a lot on all the joints, but focusing even here on the lecture portion on the knee. So a few things going on. So we have what's called the condyloid. This allows that flexion and extension, a little bit of rotation. The menisci, we'd already mentioned, so the meniscus, that's that fibrocartilage articular disc that builds up on the media or on the margins of the tibia. So it's just kind of our kneecap. The cruciate ligaments, they extend to that intercondylar eminence of the tibia and then the fossa of the femur. So we'll see a picture coming up. So then we have the ACL. This is a common tear or injury with athletes. So the anterior cruciate ligament, this prevents anterior displacement. So it keeps the tibia in the correct anterior location, hence the name anterior ligament. Then we also have the PCL. You don't hear as much about it. So that posterior cruciate, that prevents the posterior displacement of the tibia. So they're both helping to keep the tibia in place. It's just which side. So anterior on prevents the anterior displacement, posterior prevents posterior displacement. We have a couple other ligaments, the collateral and the popliteal ligaments. So these are along those tendons of the thigh muscle that help strengthen that joint. Again, we'll see them coming up. And then there's also that bursa. So we talked about like bursitis, but the bursa may result in low accumulation of fluid, which causes some water on the knee. So again, you'll focus more on this in lab, but I just wanted to kind of highlight some of these. So again, we have quite a few ligaments here. So looking at the different views, so here's our anterior view with and without the ligaments, and then the posterior view down at the bottom, again, with and without the ligaments. So again, we have that ACL. So over here, the anterior cruciate ligament is right here. So again, it's preventing that anterior dislocation of our tibia down here. And then we also have the collateral ligaments. So again, our meniscus that's there as well. So again, you'll see lots of different ligaments here that cover over top of that help connect the tibia to the femur. They go around the knee and over the meniscus, over that kneecap. That just helps really keep those bones in their correct location. And then just a few more views here of the knee. So again, you'll see these more in lab. But again, here's that meniscus that we see here, that membranous region there. Again, we have that ACL. So that anterior cruciate ligament that's going through here, again, keeping that anterior region of the tibia in place. Again, we have another meniscus here. So again, different parts that we can see here on the bone, but again, especially hitting out that ACL. Okay, now just kind of wrapping up, looking at some injuries and some things that can happen. So injury to the knee, especially lateral blows, which are common, especially in football, but other sports as well. So those lateral blows, so again, direction of the force coming here from the lateral motion. So again, from a tackle is very common in football players that destroys that lateral collateral ligament. So we can see here the tibial collateral ligament. We also have, again, that ACL that's here that can get tore. So as that force comes in on that lateral, it just pushes everything over and it rips those ligaments to complete tears. Also can damage that medial meniscus that's here. So we can see it here. And again, can cause a lot of damage and a lot of pain. It's really long surgeries, especially the ACL, to go in and repair that and allow it to heal properly. The effect of aging on our joints. So just as we age, we've mentioned some of this stuff before, but tissue repair slows. So again, the rate of new blood vessels, again, blood doesn't come all the way into the joint, but just bringing blood and nutrients, oxygen to those areas. The cartilage wears down. Again, I mentioned knee replacements, to where the cartilage is gone. We have that bone on bone kind of friction that's starting to occur. Synovial fluid, the fluid in that cavity, starts declining. So again, more rigid, less just like the oil in our car that keeps everything going. The ligaments and tendons start to get shorter and less flexible. So that's going to really decrease that range of motion, as well as the muscles around the joints weaken, which just make it harder to keep them in place. And then decreased activity due to all this other stuff decreases the flexibility and further decreases range of motion. So then some of the joint disorders that we see: arthritis, one of the most common ones. So we have osteoarthritis, which is kind of the wear and tear that we get of the bones. But then there's also rheumatoid arthritis, and this is actually an autoimmune disease or an infection that causes damage to the cartilage and damage to the joint. Lyme disease has a lot of impact on the joint, so that bacterial infection from the bacteria that causes Lyme's disease. It causes chronic arthritis that just won't go away. Gout, this is a metabolic disorder. So again, think about getting and using energy. And what happens though is they build up too much uric acid in the blood, and it gets deposited as these urate crystals in the joints and the kidneys. So again, talking about range of motion and joint health, if we have all these crystals build up in those joints, causes a lot of pain and a lot of damage. We already mentioned bursitis, but just here again, that inflammation of that bursa on the little sac area. Bunions, this is the deformation of that first metatarsal. So again, thinking about our tarsals so the middle or the metatarsals, and often is caused by shoes that don't quite fit right. So it deforms them, it kind of wears on them and wears on that metatarsal. And then the last few here to round us out, so we have, tinnitus, which is inflammation of that tendon sheath due to overuse. Dislocation, we mentioned like the ACL that's trying to prevent that, but that's just where those bones move out of alignment. Sprains, we already mentioned, again, the stretching or tearing of the ligaments. And then we also have chondromalacia patella. So the patella is the bone there on that kneecap. So this is inflammation under the patella and the softening of the cartilage in that area.